the director of the HTC here. I'm honored and excited to present to you our research in this area of point of care coagulation assay that I've been involved with for the last 4 or 5 years. And I thank Len Valentino for this opportunity to present this work. So the title of the talk today is ClotChip, a microfluidic point of care whole blood coagulation assay for hemophilia. I understand the audience is a mix of consumers and providers and others, so I'll try to tailor the explanations as much as I can, but maybe there will be opportunity during the Q&A to seek for clarifications if I go too obtuse, as they say. So without further ado, let's get started. So trying to advance the slide, let's go. All right, here we go. So first of all, the disclosures. The technology ClotChip has been licensed by a startup company named Exotech. So I've been a consultant and scientific advisory board member for Exotech. So that's one of my important disclosures. And I've also received funding from them to conduct some of the studies that will be shown in the later part of the presentation. I've been an advisory board member at some of these companies listed here, and I'm also a member of the State of Ohio Rare Disease Advisory Council. The objectives of my talk today are divided into 2 parts, and the reason for that is the part 1 is all that is public knowledge and publicly available in terms of publications or abstracts, and part 2 is the upcoming work or some things that we haven't yet made public. So we'll talk about point of care technology as it relates to coagulation disorders and specifically for hemophilia. I will explain what dielectric spectroscopy is and how the assay was developed, the microfluidic whole blood assay that we are talking about today called ClotChip. And then I'll show you some data for ClotChip in hemophilia, the detection of hemophilia as well as monitoring of factor therapy, followed by some of our results in patients who are on emicizumab. Then we'll move on to part 2, where I will show you some of our work, latest work on PK studies using ClotChip as a device, and some really upcoming exciting data in non-factor therapies showing the potential of ClotChip in that area, followed by some of my future plans. All right, so let's get going. Point of care technology for coagulation disorders. So the word point of care technology basically means in vitro diagnostics that provide real-time information on any disease state for that matter at the time and place where the patient is. So that's why the point of care. Now, the pictures below here tell you what are the different examples of that. Pregnancy being one of them, it's the most famous one of them. And then diabetes, the glucometer, the malaria testing, and then some coagulopathy as well, which is more familiar in the hospital systems. Now, the recent one that we all are now aware of, forced to be aware of, is the COVID-19 testing. We are doing testing at home, for example, with COVID-19, and that's a point of care. The idea is to shift focus from a high-cost specialized care and take it to the bedside, to the patient's side and patient's home for personalized healthcare. Now, what better example than hemophilia for personalized healthcare, right? Because that's all we do in hemophilia. It's very personal to personalize to the patient. Regarding the coagulation monitoring as it relates to point of care, obviously it's important to know what a bleeding risk is for somebody who has a bleeding disorder, or if they're on anticoagulation therapy, or if they're very sick in the ICU, for example, or on trauma. All of these situations will alter your coagulation system. We have a lot of tests in the hospital systems, what we call conventional laboratory assays. These are something like prothrombin time, PT, APTT, or factor levels that we do. These are all costly, labor intensive, and they only provide a snapshot of a particular point in the coagulation cascade or in the system and give you a narrow window into what is going on. They don't give you the whole picture. Now, this is an example of a commercially available coagulation monitor called the Coagucheck, and some of you may be aware of it. It measures PT-INR for a very specific group of patients only. So patients who are on warfarin, they need their warfarin monitored. The warfarin is already not being used as much, but this is specifically for that. It does give a very crude assessment of the coagulation process only at a specific point, and also does not provide the whole picture. So it does not, for example, provide information on the platelet contribution of making that blood clot. There are lots of microsensors that are in the works. So if you look at the literature of the last 10 years or so, you will see a variety of papers on different microsensors that are in development for coagulation monitoring. And this is an example of that. Of course, we're not going to go through all of this. This was just to show you what is out there. Different sensors, different detection techniques, and obviously with all of their limitations that are attached to it. So the talk today is of such a sensor. So before we go there though, let me just set the stage for point of care testing in hemophilia. What does currently exist, if at all anything? So as I mentioned, hemophilia is a poster child for patient-centered care, right? The care of a patient, any care that we deliver revolves around what the patient needs, what the bleeding tendency for that phenotype of that patient is, where the patient needs the factor delivery at what time, so what are their activities. We tailor a lot of this to factor levels and then to individual bleeding patterns as well. Now, but most of the point of care really in hemophilia is point of clinic rather than true point of care. So there's nothing in the patient's home that actually patient can look at to make a decision, for example. Now, the closest we have come is the WAPS hemo, for example. You can get a PK measured on yourself with a particular factor. You'll know what the PK curve looks like. You know what a PK time points are. And from those, there's a projection based on population and individualized PK to guide either replacement or to know where your factor level may be. It's a very good method. However, it's still a mix of point of clinic and point of care. Another place that we came closest to for point of care is back in the day when there was no emicizumab. Hemophilia with inhibitors, the only recourse was to do bypassing agents. And we were forced to use some point of care assays, such as viscoelastic whole blood assays, to monitor therapy with either a bypassing agents such as recombinant 7A or 5A. So I know some of you already know what a viscoelastic assay is and what those are, but for those who don't know, I'm talking about ROTEM and TEG, obviously. These are global hemostatic assessments, and this is what the machine looks like. So it's pretty bulky, it's pretty big. It creates a curve like this that is shown on this slide, and is a pin and a cup system, and the blood coagulates in this cup, and the pin picks up the coagulation characteristic, the clotting characteristics, and forms this curve, which has different parts to it. So there is a clotting time called CT, there's an MCF, which is a maximal clot firmness. So there are different parameters that you can measure, and it's from whole blood. But it is not easily miniaturized. It requires highly trained personnel. In fact, even in the hands of highly trained personnel, you can have a bit of variability as to the results that arise from this. And of course, there are other nuances that are probably not part of the discussion, some things that interfere with the natural coagulation process that are rectified in the newer versions of this. But that's the closest we have come to point of care. So that brings us to what is dielectric spectroscopy and how was that created to develop this assay. Now, at this stage, I want to mention that I am not the inventor of this technology. I am fortunate and privileged to work at Case Western Reserve University and at Rainbow Babies, where we have a case engineering school, and there are brilliant scientists there who invented this, and I'll introduce them later on in the talk, but they are the ones who invented this. I've been involved in the development of this technology as it relates for hemophilia per se. So that's what I'm going to show you. But when I say we, I mean the whole team. It's a big team that works on this. So dielectric spectroscopy is actually a well-established technique. It's a fully electrical measurement technique, and it extracts information on physiologic properties of blood in real time. What it looks like on paper, it's a measurement of permittivity against frequency. So any material can be studied this way. And as I said, it's well established to study molecular as well as some cellular compositions, a variety of biomaterials. So you look at different biomaterials, they have different pattern of dielectric spectroscopy at different dispersions that is mentioned here. So it's a well established, but when it relates to blood coagulation, that dielectric spectroscopy is called dielectric coagulometry. And the assay that I'm talking about is a miniaturized version of the same thing. So it's, as I said, it's fully electrical. The DS function, the dielectric spectroscopy function, is integrated into this microfluidic channel. So it's a very small channel, single use in a disposable cartridge that is available with this. And it requires less than 10 microliters, so about a drop of blood. And besides that, it's portable, point of care, so it can be carried in the patient's hand, just like it's portrayed in this picture. I will show you an actual device soon. So what does it do with whole blood? And that's the next question, right? How does it read whole blood to figure out what is happening in the coagulation of blood? So the main characteristics is this dispersion region that is read in the megahertz frequency that arises because of the red blood cell membrane polarization. So the interfacial polarization of cellular components is what dielectric spectroscopy picks up. And as you can see, the comparison to plasma, which does not have red blood cells, that region is not there. So this is what the chip looks like. It has an inlet and an outlet. It's pipetted into the microfluidic chamber through this, as you can see here. And then the excess is dabbed off on each side, and then there's an adhesive that covers this chamber so that there is no dehydration of blood. And then the blood is allowed to coagulate. And the reading is picked up of the permittivity from there. So what does the reading look like? First of all, coagulation is initiated by adding calcium chloride. If you don't add calcium chloride, just a saturated sample, this is what it looks like. But if you add calcium chloride at room temperature, then the curve looks like this, and pay attention to this term called T-peak. Now, I showed you in ROTEM, there are parameters, CT, MCF. Similarly, I'm introducing you to this term called T-peak. So what is T-peak? So T-peak is basically the time for maximum permittivity. So this is normalized permittivity on this axis, and this is time. So the time to maximum permittivity, these are two different blood samples, the blue and the red. And the time to maximum permittivity is measured as T-peak, as we know it's sensitive to coagulation time. So the time for a fibrin clot to form, that's what this is. And there's another parameter that is after this, which is the maximum change in permittivity that after the peak is achieved, and that we have termed as delta epsilon max. And this is indicative of or sensitive to platelet function, so the clot firmness, if you will. Now, this is all initiated in whole blood or picked up because DS is sensitive to RBC aggregation and deformation. And these are two important characteristics of blood coagulation process. So the spectroscopy is able to pick it up and to create a curve like this. So that forms the basis of this assay. So I just introduced you to T-peak and delta epsilon max. Then the next step was to make sure that they were reading what we think they were reading. So they were compared to the corresponding parameters in ROTEM. For example, T-peak was correlated or compared to the ROTEM CT parameter. So this is an experiment where argatroban was used to create an anti-thrombin effect in blood. So if blue is the normal curve with T-peak, argatroban or anti-thrombin effect created this curve, and then thrombin corrected it. And the same thing is seen in ROTEM here. And this parameter, CT in ROTEM, was what was compared to T-peak. And this statistical graph that you see is the result of that comparison. So the R, the closer it is to 1, the more perfect the correlation is. So if R is 1, that means there is a near perfect correlation or perfect correlation between one and the other. So here the R was 0.99, that means it was very well correlated. So that was the T-peak parameter. The delta epsilon max, as I mentioned before, is the platelet activity parameter. So in this experiment, cytochalasin D, which is a inhibitor of platelet activation, was used at different concentrations to show the change in delta epsilon max as the platelet inhibition happens. And then that was compared to MCF or parameter of ROTEM. And here you can see the comparison again was pretty good as well between the delta epsilon max and MCF. So the next step was to figure out whether ClotChip was able to differentiate normal from abnormal or coagulation. So this is data for 15 healthy volunteers. Now, there is subsequently data for way more number of healthy people, and there's a normal range. Like any test, like a PTT has a normal range, like factor levels have a reference range. Same thing, the T-peak has a range as well that is depicted here. And the healthy volunteers had, the curves look like this. And in coagulopathy, uniformly, the T-peak is shifted to the right or prolonged as it should be. And there's a variety of different coagulopathies that were tested in this experiment right here. And there was a clear difference between one and the other. So it was sensitive to coagulation defects. What about platelet inhibition? So this is ex vivo. We did not, this is not experimenting with patients who actually have a platelet disorder, but this was artificially created. So this was ex vivo. So blood taken from 10 healthy volunteers with different concentrations of aspirin, so causing the delta epsilon max to differ based on how much aspirin was there in the blood sample that was added, was compared to the gold standard for platelet aggregation, which is aggregometry, light transmission aggregometry. And you can see the correlation here that is depicted here with delta epsilon max against this parameter in aggregation. And even beyond that, the delta epsilon max was differed between different concentrations of aspirin, as you can see here. So that brings us to, so that was how the sensor was created, and it was functionalized, and it was tested in different environments. After that, I will show you the data for ClotChip in hemophilia detection, as well as monitoring of factor therapy. So you're by now familiar somewhat with the curve that I showed you. So this is a curve. We have tested several patients with hemophilia, some with inhibitors, some without inhibitors. And some of this work was pre-emicizumab era. So a lot of people with inhibitors were not on emicizumab then. So this representative curve on hemophilia patients shows you the difference between the inhibitor and non-inhibitor. So this is a normal curve, the blue curve. So you can see the T-peak that lies between 0 and 10 minutes right here. So that, again, there's a reference range somewhere here that ends. The T-peak in patients without inhibitor, so the red curve, is prolonged. Obviously, it's way prolonged than the normal. So it's between this area. And then the patients with inhibitor, it's significantly prolonged, even more than that. So not only it's elevated in patients with hemophilia, but it further prolonged in the presence of an inhibitor. This was statistically different between normals and abnormals, and even within abnormals, with or without inhibitor, it was able to differentiate based on just T-peak alone. Next, we wanted to see if giving factor therapy or bypassing agent to somebody with an inhibitor actually corrected the abnormality, which we know it does, but was the assay able to pick it up? So let me walk you through these curves. So throughout the presentation, you're going to see a lot of these curves. So by the end of it, I'm hopeful that you will know what a normal curve looks like and what an abnormal curve looks like. There are numerical values associated with these as well. So the T-peaks in terms of minutes or seconds. However, it's easier to show you in this way so that it's represented graphically well. So let's walk through this. So there are 4 different curves here. 2 of them are in patients without inhibitor, and 2 are with inhibitor in different colors. So the first, the green one, the patient without inhibitor with hemophilia. There's no inhibitor, so that's the T-peak. Now, as you can see, the T-peak is prolonged, quite prolonged. It's in this box right here in 20 to 30. So this was a factor 9 inhibitor patient that was tested. So, and then the patient was given a therapeutic dose of factor 9, recombinant factor 9. And then you can see the curve normalized. It shifted towards the left now. So the blue curve, that's what it is. It shifted back to, so that's post. That was about 30 minutes after the factor was given. Again, a blood sample was drawn, and the T-peak was measured on that. And then you can see the correction. In case of an inhibitor, so this is a T-peak in somebody who has an inhibitor with hemophilia. You can see how prolonged that T-peak is as compared to normal and as compared to somebody without an inhibitor. Once they got a bypassing agent, in this case, it was recombinant 7A, the curve normalized back to the black curve that you can see here. So it was very well, it was able to pick up the correction very well, and was very sensitive to coagulation factor therapy that we administered. One more thing that we learned in these sets of experiments was the fact that we were able to differentiate between inhibitor and non-inhibitor. So this is post-therapy, this is pre-therapy. These are data points after correction, and this is comparing the healthy. Now, one thing to note here is that I made a differentiation between tolerized and non-tolerized. So this was, again, an era before emicizumab, where obviously patients underwent a long and prolonged tolerization process. Some of you may remember that. So the blue triangle that you can see here, or diamond that you can see here, is somebody who's tolerized with inhibitors now in the range of hemophilia without inhibitors. Whereas if you're non-tolerized, then your T peaks are really prolonged beyond this range. Now you can see this guy is really way up because we have some patients who really bleed quite a bit with inhibitors, and their phenotype is very different from somebody who may have a similar level of inhibitor, for example. So this was the conclusion from here. That brings us to the emicizumab era, or we have tested the assay in patients with emicizumab since then, with several patients, but this was in the initial period when we were when we were starting patients on EMI afresh. So initially, obviously the patients with hemophilia with inhibitors were started on EMI, as it was approved in those patient population. So we have done several patients, but I'll show you one of the curves that belong to this patient. So we wanted to see whether ClotChip T-peak was able to pick up emicizumab in a patient's blood, for example. So we did an experiment where the patient came to the clinic for starting emicizumab. In those times, we used to call them, and we used to do every infusion of emicizumab, injection of emicizumab, at least the initial ones in the clinic. So this was during the first one. So the pre one is before the patient ever started emicizumab. So this is somebody with inhibitors, obviously. So you can see that the T-peak is very prolonged, obviously. And within 2 hours after giving emicizumab, the curve started shifting towards the left. So it's not normalized yet, but it started shifting towards the left. Within a week, it's obviously become normal. And then at 8 weeks, we measured again, it's still in the normal range. So it was, there was a decrease in the T-peak as expected, as with factor therapy, for example, in response to emicizumab and patients who had inhibitors. And this is the data on 3 patients. And as you can see, there are different time points for these, not everybody at the same time point. First of all, they all had different T-peaks at baseline. You can see that. And some of it is correlated with their bleeding phenotype as well. So for example, this patient right here at baseline and then 2 hours. So all of them took about a week to come back to the normal range, but then they stayed there. They don't go anywhere, those T-peaks, because as we know, there's a very steady concentration of emicizumab once it achieves that value, and then it stays there, which is what is reflected in this. The only time this would become abnormal is if somebody develops antibodies to emicizumab, which is very, very rare phenomenon. Obviously, we haven't come across it yet in our center, so we don't have data to show that in this assay, for example. Next, we wanted to see whether patients without inhibitors. So by then, the emicizumab was approved in patients without inhibitors, and we tested some patients on who did not have inhibitors, and I'll show you one of those patients' examples here. So this is a patient where a patient with severe hemophilia A who did not have inhibitors. So the blue is the pre-curve. Within 4 hours, the curve started shifting to the left. The T-peak shifted to the left. And if you remember, we do give recombinant factor 8 for the first 2 to 4 weeks after you start emicizumab. Till their levels are, becomes more maintenance levels of emicizumab. So we gave the patient recombinant factor 8 in the clinic and remeasured the T-peak. And of course, as you can see, the curve from the red to the light pink, it shifted again to the left. And at 1 week, it comes back to this range because the effect of this 8 is gone. So addition of factor 8 was sensitive. Obviously, it shifted the curve to the left. And then at 1 week as well, when the second dose of recombinant factor VIII was given, and again, it did the same thing. So a decrease in T-peak was observed in response to emicizumab therapy, and then recombinant factor VIII further decreased that T-peak compared to ME alone. The next sets of experiments were more for us to understand the sensitivity of the assay to different concentrations of emicizumab. So we wanted to see whether different levels of emicizumab changed the T-peak at all. And so we did some ex vivo spiking studies. That means we took blood from these patients and we artificially added ME to their blood samples. And so this was not the patient that got ME, but this was just the blood from hemophilia patients where ME was added. So this is the ex vivo ME treatment in either patient without inhibitors or with inhibitors. So without is obviously a lower T-peak, the red, the black circle right here, and the black square is the one with inhibitors. So obviously you can see the T-peak is way prolonged at baseline. That means before the ME was added, and then different concentrations of ME. As the concentration went up, the T-peak went down as expected. So there was a concentration-dependent decrease in the T-peak, but it kind of stopped at some point, and then it was constant. It did not change much after that. We also added recombinant factor VIII to the sample. So these were non-inhibitor samples at different concentrations of ME, either ME alone, or when different concentrations of VIII was added. So there's a 60 IU per DL, 80 IU per DL. As you can see, there's a decrease in T-peak corresponding. Now, remember, this is the normal range. So we're going beyond that now because the concentration of ME is high in these cases. Now, something interesting to note here that we added factor IX to the blood sample from a factor VIII deficient patients where the ME was also added. So we know this now that IX is the driver of the reaction, so to speak, and in ME. And then addition of 9 at this concentration actually created the lowest T-peak that we saw in the ME population. So obviously we now know that this is true, and it's correlated with thrombin generation as well. In the inhibitor samples, so these were still non-inhibitor sample, but we added FIBA or NOVO7. We wanted to see whether there's a difference between FIBA and NOVO7 as it relates to T-peak. So there was a small difference. As you can see, the T-peaks are different after with ME alone, and then different concentration of FIBA, different concentration of 7. So 7 did not decrease the T-peak as much as FIBA did. We correlated all of these samples to thrombin generation. So I showed you rotem correlation curves, and these are thrombin generation correlation curves. And you can see that the T-peak is correlated to endogenous thrombin potential, for example, as well as to peak thrombin. So we had a pretty good correlation to both of these parameters in the assays. I want to shift gears a little bit. Now, this was a lot of data in hemophilia patients that I showed you. And I just want to talk about how do we get the assay or the use of the assay in the patient's hands. So from clinical application from the lab to the patient's hand. So before we talk about that, I just wanted to mention at this point that the ClotChip assay has been, the technology has been licensed to the startup called Exatech, which is based in Cleveland. And the CEO is a physician himself, John Zach. And this was a few years ago now. There's significant funding that has been raised as a result of that relationship because it's a great startup company. And because there was a prototype created as to what the device will actually look like a glucometer was the inspiration from there. So this is the beta unit of one of those and a sensor that looks like that. So the blood that goes on the sensor that is put in the device, just like a glucometer does in patients with diabetes. So what could be a potential clinical use of ClotChip in hemophilia, right? That's the next question that comes based on the data that you saw. And in patients with hemophilia without inhibitors, patients with ME, there's a lot of different scenarios that we have. And now, of course, we have, way different scenarios as well beyond that. So we'll talk about that in a minute. But what could be a potential clinical use of ClotChip in hemophilia? Now, point of care assessment, we talked about this. Factor levels per se is not practiced currently because we don't have that. We don't have ability to to instantly know what somebody's factor level is, for example. But one size doesn't fit all, right? There's definite role for individualized therapy. We are aware of that. We kind of try to practice it in different fashions. However, there are significant problems with individualized therapy as well. There is within and between patients differences of how PK behaves, how a particular factor behaves pharmacokinetically. We obviously assume once we do a PK level, we assume that the factor level is going to stay the same, follow the same curve at all times, whether there's activity involved or at rest or during surgery, for example, because the consumption might be different. You have to test each concentrate. So we assume that with all concentrates, it's going to be different. What if there is no particular constant that you want is available in the hospital? And that happens sometimes, especially in community hospitals. The PK may not follow the same curve. And then, of course, if you have either a subclinical or a clinical inhibitor and you tolerize, that can change your PK as well. We know this. More recently, gene therapy data has shown us there is unpredictability of factor levels as time goes by. The factor levels can modulate up and down after gene therapy as well. And then finally, of course, there's utility and ability of monitoring possibly novel non-factor therapies. But the bulk of the use could be in actually figuring out factor levels in different situations. And I'll give you an example. Obviously, during activities, there is a certain bleeding risk that is associated. Now, there is clear data that if your factor level is beyond a certain level. So in this data, obviously 94% of patients above the level of 15 were bleed free. So if you are 15 and above, you have a pretty good chance that your bleeding risk is pretty minimal during certain activities that can be then categorized into a safe zone or a moderate risk zone or a dangerous zone. So you can create different zones based on your factor levels. And then that could be told to the patient who can then modulate their activities based on where they are if they know what the factor level is. Now that's the crucial point here, if they know what the factor level is at all times. And that currently is not available to us. But to get there, we'll have to do some more studies to duplicate pharmacokinetics with ClotChip as it's done currently without traditional methods. And I will show you that in a second. But that's where I think the part one ends where, as I said, the data that is already public and published, I have it here. So let's summarize part one first before we go to part two. So ClotChip T-peak is sensitive to coagulation time and correlates with CT parameter in totem. I showed you that. The delta epsilon max parameter is sensitive to platelet function, and it correlates to MCF parameter in totem. T-peak differentiates between normal and coagulopathy samples very well. It's prolonged in hemophilia. We saw data on that. It's further prolonged in somebody who has hemophilia with inhibitors. And of course, it normalizes if you're tolerized versus not. ClotChip T-peak is able to be corrected back to the normal range that's established once patient is administered factor or bypassing agent if they have an inhibitor. And then finally, ClotChip T-peak is sensitive to presence of EMI. Now, one can argue that you really don't need monitoring of anything during EMI. That is correct. The only possible use in EMI patients might be that there is it's a small risk or a small risk of developing antibodies that may make the use of the ClotChip relevant in those patients. So that's the summary of part one. And at this point, I do want to acknowledge. So, we obviously keep the acknowledgements at the end, but I want to do it at this point at part one, because a lot of effort has gone into creating this data. So at this stage, I want to acknowledge all the folks that have made this possible. First and foremost, obviously, the engineering colleagues at Case Western, who are really brilliant and have brilliant ideas and take our problems and the problems that we take to them and create solutions that are wonderful as these. Pedram and Mike are two co-inventors of this technology. And of course, Anirban, a lot of folks know as well, and Umut, who are part of this team that I have the privilege of working with every day. And I'm blessed to do that. And then, of course, my clinical colleagues, Alvin Schmeier and Walita Naik and Evi Stavru, who not only contribute patients and samples, but also give advice and contribute to this research efforts. Nothing could happen without the graduate students that do all of this work, and importantly, funding, right? So if you don't have money, without money, there's no mission, if you know that. So, and our chair that I hold, Dominic Puno, who's actually a patient of mine, is really helpful in creating these data and putting an effort towards this. And then a lot of other agencies that help, including DoD, Coulter Foundation, Exotech, the company itself, and of course our institutional funding. I'm very blessed and privileged to work with a fantastic team at the HTC, the nurses that day in and day out help me out. And I cannot do anything without these folks, and they make my job look so easy. So I cannot thank them enough. They're all pictured here. But the most important, obviously, is our patients and the parents that each and every day, are pleasure to take care of and contribute to any research that we ask them to take part in. All the blood samples that you saw from some of these patients, they come to our HTC that's pictured here. So that is the end of part one. I will now go to part two, and then we'll take the questions at the end of the session, if it's okay with everybody.